es una gran investigadora que lleva muchos años trabajando el tema de adicciones, de VIH y de tratamiento y otras áreas afines en el tema de drogas. Y bueno, hemos trabajado con ella desde el 2000 en las encuestas mundiales de salud mental. Ella coordina el tema de drogas y pues ha sido una gran aliada en muchas de las cosas que hacemos. Ella es de Australia, es profesor de la Universidad en Australia y también es investigadora principal de un centro de investigación en drogas y alcohol. Ella pues tiene un doctorado. En su doctorado ella evaluó la comorbilidad y el uso de drogas relacionada con la salud mental en la población de Australia. Fue en el 2003. Y también tiene un puesto honorario en la Universidad de Melbourne y también en el Instituto Murdoch para Salud de los Niños y en la Universidad de Washington y también en el Instituto de Health Metrics, que son los que hacen las evaluaciones de la carga global de enfermedad. Ella hizo el análisis completo para sustancias de todo el mundo en el 2010 y ha seguido trabajando también con este grupo. Y ella ha hecho muchos estudios epidemiológicos analizando pues, poblaciones en la comunidad y en la práctica clínica con grandes bases de datos, pero quizá también es importante que ella ha trabajado sobre el desarrollo de indicadores y de metodologías alternativas para evaluar los temas de drogas, así que estoy segura que tendrán después de su conferencia muchas nuevas ideas también para sus tesis y sus publicaciones. Ella, ¿verdad?, tiene un índice H de 80 en Scopus y tiene más de 240,000 citas a sus trabajos. Entonces estamos hablando de una de las principales figuras en el mundo en este tema y estamos muy encantados de que esté aquí con nosotros. Ella no sabe lo que estoy diciendo, pero ya se apenó. So I'm talking about your work. Entonces, bueno, estoy muy contenta. También les agradezco a todas las personas que están siguiéndonos por el canal YouTube. Y pues vamos a oír su presentación y después tomaremos preguntas para poder terminar la conferencia contestando las preguntas que puedan tener. Muchas gracias. The floor is yours.
Thank you, Maria Elena. I have to apologise, I don't speak Spanish, so many apologies. So I also have no idea what Maria Elena said. So look, I'm really thrilled to be here today. Mexico City is wonderful. We've been here for a few days now. And I've collaborated with Maria Elena and some of her team for many years, so it's lovely to finally visit where you work. I'm going to be talking today about one particular piece of work, but it sort of represents a program of work that we've been doing over the past more than 10-15 years, which is really around synthesising evidence. The review that I'll be talking about today is synthesising epidemiological data, but our teams work on synthesising data on the epidemiology of drug use, the risks of harms, and also synthesising what evidence there is for interventions to reduce harm, whether or not that be treatment or other harm reduction interventions. Just want to acknowledge that Matthew Hickman is in the audience as well, and he and I have been working on a lot of those things together. Matt is from Bristol University and very core member of the team. So just want to acknowledge the fact that there is a very large group of people who was involved in this specific review. and they're from my university, University of New South Wales, but also Matthews University, University of Bristol, as well as other universities, UN agencies, and international NGOs. So just a bit of background. So we first did a review of the epidemiology of injecting drug use that was published in 2008. And that was when we were running a reference group to the UN on HIV and injecting drug use. Since then, we have undertaken reviews of not just injecting in HIV, but also injecting in hepatitis C. We updated them in 2017, and then recently updated and published the third iteration of that review last year. So the review that we did this last time was we actually looked for a lot of information. I'm only going to present a small piece of that today. But we were focusing on what is the existing evidence around the prevalence of injecting in each country around the world. What are the characteristics of people who inject drugs? So demographic characteristics, social characteristics. We also looked for information on exposure to risk behaviour and risk environments. So experiencing homelessness, experiencing incarceration as risk environments, but also injecting risk, sexual risk and other personal risk behaviours. We also looked for data on physical and mental health of people who inject drugs. There's often a lot of focus, particularly on HIV and more recently hepatitis C, but there are a lot of other issues that it's important to get a sense of the extent to which people who inject drugs may be experiencing other health harms, both physical and mental. And in this review, we also looked for information on what interventions are available for people who inject drugs. Available for HIV prevention, treatment and care, availability of treatment of hepatitis C, and also availability of other interventions, particularly opioid agonist treatment and needle and syringe programs. So the approach that we used in this review is consistent with our other reviews. So it's a sort of a multi-stage review. So the first one is we look at the peer-reviewed literature. But for a lot of this kind of data, surveys of people who inject drugs, they often don't end up getting published in journals. So we do a very wide-scale search for grey literature that is reported on websites in the internet. We also liaise with international organisations that either collect this kind of information or fund the studies that this information is obtained from. So UN agencies, the Global Fund, EMCDDA and the Harm Reduction Organisation, as well as other organisations involved in that kind of work. And additionally, we ask people around the globe whether or not they have information that might be of help to us, and consult with people in country where we have information gaps, or we want to make sure that the information we have obtained is correct. So for this most recent review, we screened just over 40,000 papers or reports that had been published since 2017, which was when the previous review had been searched until. Of those, just over 700 were eligible, and we added those to the 1,100 that we had from the previous review. As I said before, we consulted with UN agencies, particularly the United Nations Office on Drugs and Crime, who also collect information on the prevalence of injecting and the prevalence of HIV and hepatitis C. And we worked back and forth and each shared information and reports that the other organisation or other group hadn't found, and were able to come to a pretty close to consensus, with the exception that in the World Drug Report, UNODC publishes estimates that don't have a source or that have come without any information around it, whereas we don't accept that level of information. So in terms of what we found in terms of data availability, so in our first review, we found evidence that injecting was occurring in 148 countries out of 207 countries or territories. By 2022, when we did the search, that had increased up to 190 countries globally. There was also an increase in the number of countries where an estimate of the prevalence of injecting had been made. So from 61 countries in 2007, increasing to 102 in the most recent review. So overall, we've got 99% of the world's population live in countries where injecting has been documented, and around 87% of the world's population live in countries where there'd been some attempt to make an estimate of how many people were injecting. Sorry, this might be a little bit small for some of you at the back, but the blue is 2022 review and the red is the earliest review. This is basically to show 2 points. On the left-hand side is where there is evidence that injecting is occurring, and what you can see, the second row is Sub-Saharan Africa and the second last row is the Caribbean, and both of those regions we've had a real increase in the number of countries where injecting has been identified. That could be a combination of more information being available that was occurring previously, but in some countries we definitely know it's probably a more recent development that injecting has started becoming one of the routes of administration of drugs in those countries. The right-hand figure is where countries, the percentage of the population where a prevalence estimate had been made. What you can see, the second from the bottom in the Caribbean, almost no quantification of the number of people who inject drugs has been made. That's pretty similarly the case in the Middle East and North Africa. There is no quantification of injecting in the Pacific Islands, but there has been a real increase in efforts to estimate the number of people who inject drugs in Sub-Saharan Africa over the past 15 years. So this map is showing the estimated prevalence of injecting. So there's grey areas, there's light grey areas and dark grey areas. The dark grey indicates that we know that injecting is occurring, but we don't know how many, no estimate has been made of how many people. And then the light blue indicates a lower prevalence, and then the darker blue indicates a higher prevalence of injecting. So what you can see in this map is the United States and the Russian Federation are among two of the countries that are estimated to have amongst them the higher prevalence of injecting. And you can see there in Mexico the prevalence is estimated to be in the lower end of the scale. Overall, we estimated that around 14.8 million people globally had injected drugs in the past year, which is around 0.29% of the population. I'm really worried about the people up the back because you're not going to be able to read these, sorry. This is just showing you the estimated numbers by region and showing you on the left the estimates that we made in 2017 and on the right the estimates in 2022. Overall, if you look at the two sets of estimates, the number of people estimated to be injecting has decreased between the two reviews. So the previous estimate was around 15.6 million and now 14.8. But there's a little bit to unpack in that. So the first thing is there's a lot of variation across regions. So in some regions, prevalence was really estimated to have increased. So in North America, an increase of around 30%. We think that probably reflects an increase in the United States. There's also changes in the countries where we had estimates. So for countries where we didn't have an estimate before, we imputed that estimate. So when a country made its own estimate, we then used the country-specific estimate. So we're not exactly comparing apples with apples in terms of looking at potential changes. The other thing to bear in mind is that sometimes we had a new estimate for a country, but they might have used a different method. So that makes it difficult to make direct comparisons. So I mentioned before that we looked at information, we extracted all information from all of the surveys that we located around the characteristics, and we looked for a wide range of characteristics. This is just a few. So globally, we estimate that around 19% of people who inject drugs are women. Around 1 in 4 are under the age of 25. About 9% identify as lesbian, gay or bisexual, and around 0.4% identify as being trans and gender diverse. That's the global estimates, but for all of these characteristics, there is substantial variation geographically. So for example, for women in Australia, where I'm from, around 1 in 3 people who inject drugs are women. If you're looking at a country like India, it's less than 5%. So there's a really, really big variation that reflects a whole lot of cultural and social variables. Similarly with age, in countries like Australia and the United Kingdom, there's a much older injecting population than some other countries, which is a combination of the extent of time that injecting has been occurring in the country, but also reflecting the demographic profile of the general population in countries, some countries having much younger populations. And I mentioned before things around risk exposures and physical and mental health. So again, these are pooled at the global level. There was a lot of variation for most of these at a country level in what the profile looked like in terms of people's exposure to risk, and also in terms of prevalence of different health outcomes. But globally, we estimate that 1 in 4 people who inject drugs has recently been homeless or is experiencing unstable housing. 6 in 10 have been incarcerated in their life at some point. About 3 in 10 have recently injected a syringe that had already been used by somebody else. About 1 in 5 had recently overdosed. 1 in 3 had recently had a skin or soft tissue infection, and over half had recently experienced depression. I'm going to go into the HIV and hepatitis C data in a little bit more detail, but in showing you those other 3 health outcomes, you can see that they're very prevalent. So there's a real need for us to be mindful of, that people may be experiencing a wide range of health outcomes other than infectious disease. So this is the map showing the country level data on HIV prevalence among people who inject drugs. Excuse me. And as the purple indicates higher prevalence, the more you get into the yellows, it indicates lower prevalence. And you can see that there's substantial variation across countries in the extent to which people are living, people who inject drugs have been exposed to HIV. And this is current hepatitis C prevalence. Again, there is substantial variation, but by and large, hepatitis C prevalence is much higher than HIV prevalence at a global level and typically at a country level. Oh, what happened? Okay. Okay. So I mentioned before that we looked for information in each country on the availability of different interventions that could reduce or prevent harm among people who inject drugs. So in this slide I've given you most of the ones that we looked for. In this review, we also, for the first time, looked at whether or not naloxone was available to people who inject drugs in the country, and also countries where there was some kind of supervised drug consumption facility. What you can see for those, and I won't talk about these any further in this talk, is they're not very widely available at a country level. This is not even quantifying how much of it is being provided, but you can see it's a real minority of countries that have either of these interventions available. So in the top rows, the top two rows are around opioid agonist treatment, so methadone and or buprenorphine. And then the 3 rows underneath that are around needle and syringe programs. What you can see from 2007, we found 70 countries had OAT available. That increased to 89, so just under half of countries having OAT availability in 2017, but only one more country than the 2017 number was implementing OAT at all in the country. In terms of coverage data, we did see a big increase in the number of countries that are now quantifying how many clients are receiving OAT, which is really the important thing. I mean, it's good to know if it's available, but you really want to know how many people are receiving OAT, because you want to have high-level coverage of OAT for there to be a beneficial effect of OAT across the population of people who inject drugs. Similarly, for needle and syringe programs, we saw an increase between 2000 and 2017, and basically no change in the number until 2022. Some countries had started implementing NSPs, but countries, particularly in Latin America, had stopped implementing those interventions. So overall, the number of countries is about the same, but it reflected shifts in both directions to increasing some new countries, and sadly some countries no longer providing that intervention. So I mentioned before that, yes, you want to know if things are available, but you really want to know how many people are receiving them. So this map here, and you'll note that there's a lot more of that dark grey colour that indicates countries that have absolutely no availability of methadone or buprenorphine. The Russian Federation is a big one, but you can see in most countries in sub-Saharan Africa, there is no OAT available in those countries. And what you can see, that the light blue indicates very low level coverage, and you can see that there's a lot of countries that, although they have availability, not very much of it is being delivered. So in many countries, particularly those who are more dependent or have historically been dependent on external funding from places like the Global Fund, sometimes things might be trialled as a pilot or 1 or 2 sites, but it's not actually expanded to become a national program yet. So what you can see in the dark blue is there's only a few countries, and they're typically Western Europe, Canada and Australia fall into that camp where there is high level coverage. This is, I know probably you can't even read it at the front row, these numbers are very small, but this is really what we did in 2017 and 2022, the last 2 columns, is classified countries according to the UN WHO guidelines on low, moderate and high level coverage. And what you can see, as I said with the map before, you can see Australasia, Western Europe and South Asia were the only regions that had high coverage. So this is a map that's showing needle and syringe program coverage. The darker purple indicates higher coverage, the light purple indicates low coverage, and the dark grey again shows you countries that have absolutely no availability of this intervention. So as I mentioned before, in many South American countries there is no longer needle and syringe programs available at all, and many countries in sub-Saharan Africa. And in this, for this intervention, it's only Australasia, basically Australia, where there is high level coverage of needle and syringe programs. This is a little bit busy, but I'm hoping the colours will tell you the story. The first 2 rows are around needle and syringe program coverage, and then the bottom 2 rows are coverage of opioid agonist treatment. And this is of the percentage of people who inject drugs, how many of them are living in countries with different levels of coverage. So the green is high coverage, and what you can see is that only 2% of people who inject drugs live in a country where there is high needle and syringe program availability. And in the bottom row, you can see only 8% of people who inject drugs live in a country where there's high coverage of opioid agonist treatment. The red bars, which are the biggest bars, are all low coverage. So most countries that are implementing these interventions are not providing very much of it to cover the population. This here is just showing you what you want everyone to be in is the top right-hand corner, which is high coverage of NSP and high coverage of OAT. And there's only 5 countries in the world that have both of those things, and they are in Europe, Western Europe, Australia and Canada. So just in summary, we found a lot of variation in both the amount of data on health and social risks, but also the prevalence of those health and social risks varied a lot geographically. We also saw a lot of variation, which we've seen in the previous reviews that we've done, in how many people are estimated to inject in a country when we know that it's occurring. And also the profile in terms of bloodborne virus prevalence, patterns of drug injecting and the kinds of drugs that people are using, and also the age and gender profiles of people who inject drugs vary enormously from country to country. And those things are all really important when you're thinking around what are the requirements in terms of policy and program planning. We also documented that really substantial proportions of people who inject drugs are exposed to risk environments and also are engaging in risk behaviours that will increase risks of a range of health outcomes. And really, by documenting all of this, really what we wanted to do is reinforce that you really need to have quite a comprehensive view when you're thinking about reducing harms that also include exposure to risk environments. I mentioned before the issue around the changes in the estimates of the number of people who inject drugs. There's also changes in service coverage. So some of the variation that we saw in coverage reflects real changes in service delivery, so the removal of needle and syringe programs in Latin America. But some of the changes reflect a change in the availability of data and also the quality of the data that are availability. Sadly, the take-home story is that most people who inject drugs live in countries where there isn't widespread availability of the 2 interventions that have the strongest evidence of benefit for a range of outcomes, and that's OAT and needle and syringe programs. And although we saw a modest increase in coverage at the global level, we're still talking globally about very low levels of coverage, sadly. There are limitations both in the data and in terms of what we can interpret from this. And that relates to changes in methodologies when people are making prevalence estimates. The scarcity of the data for some of the things that we're looking for means that we're less confident around some of the characteristics that we wanted to summarise. And a lot of countries don't actually collect or make available programmatic data on service coverage, which makes it difficult to get a sense of how good coverage is. So I'm just quickly going to give you a little update of a new review that we're doing. I'm nearly finished. I just wanted to let you know that this work is ongoing, and very happy to talk with anyone who's interested in this topic. The review that I talked about just now is around people who inject drugs in the community. So what we are doing now is basically the same review, but focusing on people who are incarcerated. So we're looking at the characteristics of people who are incarcerated, prevalence of HIV and hepatitis C among people who are incarcerated in each country, and also looking at those prevalences among the subpopulation of people who inject drugs who are incarcerated. We also want to summarise existing evidence on history of injecting drug use and other drug use, sexually transmitted infections, tuberculosis and other health conditions that people who are incarcerated may be experiencing, and also the prevalence of injecting and sexual risk behaviours during incarceration, but also prior to being incarcerated. We're also looking at interventions, so the similar range of interventions as we did for the community-based review, but also looking at vaccination for some diseases and treatment related to HIV and hepatitis C. So where we're up to at the moment is we screened just over 50,000 papers and reports. We've gone through the same process of asking people for information, looking at the grey literature, and we've got about 3,000 studies that either provide information on the epidemiology or service availability. So we're going to go through the same process but document that for in the prison setting. And that's where we're up to. So thank you very much for listening. The two papers on the most recent review, they're both open access, so you can just if you're interested in them, they're available for everyone. And that's my email if you've got any questions. Thank you.
Tengo algunas preguntas de las personas que nos están viendo, pero sí, primero quisiera saber si ustedes tienen preguntas que hacer, comentarios. Adelante. ¿Vas a hablar en español? Está bien, digo, si hablas en inglés mejor, pero si no, les traduzco.
Very good question.
The second question is, has there been found any correlation between any personality traits and drug
Yes.
injection, drug use? Yeah.
Well, I'm glad Matt's in the audience, because if I stuff up the answer to the first question, you can help me. But it's a really good question. So, I mean, as you're probably thinking about, often people who inject drugs, it's a pattern of behaviour that is very stigmatised. And so, but people, often with good reason, do not feel, don't do it in open. And when you do try and estimate it through things like household surveys, which is how lots of things are estimated at the national level, it's always going to be an underestimate when you use that kind of method for several reasons. One, people might not feel comfortable disclosing it. Two, often the places where people who inject drugs might be more likely to be living or at the moment are often excluded from household surveys. So prisons, hospitals, people who are homeless, people who are living in shelter, all of those are always excluded. So you know that you're going to miss people. And so we know that it's likely to be a real underestimate, because even when people are interviewed, often they will not say, yes, I've done that. So the preferred method is to use what is called an indirect prevalence estimation approach. And that's basically using other data sources to make an estimate of that somehow identify people who inject drugs. And from that, you estimate the whole population of people who inject drugs. So the simplest one, they vary in their complexity and robustness. Matt does very good ones, but they're very complicated, so I'm not going to explain Matt's one. But a simple example of that would be if you were trying to estimate opioid dependence, and you say, right, well, we know that there's 1,000 opioid overdoses in our country, and we're pretty confident that's the right number. And then from another study, you get an estimate of what proportion of people experience an overdose. And so you kind of use those two pieces of information to generate the estimate. Yeah. Is that good enough, Matt? Right.
more related to that, that as you saw with the figures, that there is a massive opportunity within Latino Americano and Central to improve the estimates. And I guess what the other thing that Louisa was alluding to is that maybe injecting is only part of the story now, and maybe because of all of the different opioids, different routes of transmission, that the new focus of the new reviews will be on opioid dependence or methamphetamine or cocaine stimulant dependence, and that will be a sort of the new sort of work effort, and in particular, I think in Latin America's opportunities to try and get better, robust estimates for all of you young people to do in your work. Yeah.
Thank you. Otra pregunta.
Personality
Yes.
traits. Yeah, a lot of people look at that. I think the short answer is I don't think it's related to personality. Do you agree with that? Maybe, yeah. Yeah, but not personality disorder per se. Yeah. Yeah, no, I wouldn't have that as something that you think is really a big feature going on. It's more around availability of drugs, knowing other people who use drugs, you know, maybe not going so well at school, hanging out with other people, you know, who are also, you know, and just, you know, that, yeah, yeah.
También hay una comorbilidad muy grande con trastornos mentales, pero no necesariamente de la personalidad, ¿no? Thank you. Ok, había otra pregunta atrás. Bueno, entonces, mientras yo se los traduzco a inglés, o Claudia también puede. Bueno, mientras se animan, les voy a hacer preguntas
Stunned you into silence.
que mandaron sus compañeros. They want to know more about the indicators that you use to do these evaluations.
What are
These estimates, what other indicators you use, plus using drugs, do you use other indicators, or?
For what are the information we're extracting?
Yeah.
So we kind of standardize everything, so we want specific variables. So we have a big database that people extract the information from. So we're really focusing, so for drug use, it's on more recent. We ask about lifetime, but also past 12-month use. We also look for information on specific routes of administration. So have they used cocaine? Did they inject cocaine? Do they smoke it? Do they snort it? And we do that for all of the drug types. For the mental health indicators, we did need the assessment to be using a standardised tool, but we also had a variable that was around self-report, which is not as reliable, so we separately extracted that. So we kind of had a lot of rules around the specific information that we were looking for.
Okay, thank you very much. Some time ago, in one of your papers, I don't remember which one, but it was not a very new one, when you were analyzing the information from different countries on substance use, and you made an assessment that was very interesting about the proportion of people using drugs that came from countries where the policy was prohibition against other policies. Can you tell us more about that? And if you are looking, I mean, you're still seeing that?
So that was using the World Mental Health Survey. So that, when we did that one, I think we had 18 or 24 countries. So I presume you all know Maria Elena is a very core member of that group. And so what we did was they collected information using a household survey. So yes, I know, but it's the same survey across countries. And people were asked, have you used this drug? And if so, how old were you when you first started to use it? And what we did was we looked at the pattern of use across countries, both in the overall prevalence, lifetime prevalence of use, and when people were starting to use. And there was no clear, we found much higher rates of use in the United States, where there's a pretty punitive kind of set of, or there's been some changes since, but pretty punitive drug policy in that country. We found much higher levels of drug use there than we did in the Netherlands, which historically had a much more liberal policy, particularly in relation to cannabis use. So in terms of thinking around, the policy of the government and the country, there's no clear link between just being more draconian, more draconian in your policy and that necessarily having an effect in reducing use, because clearly there's countries that had much more liberal policies and use was much less of an issue. So I think it underlines the fact that, sometimes the governments and also the community, and the governments, because that's often what the community think that, by just making things illegal and saying these are bad, that it will mean that people won't do them. And the answer is no, that doesn't really work. And what it can actually do by having, incredibly punitive policies, it actually can cause people who are, using drugs to experience even more harm. So it can sort of have an even worse effect in terms of the burden on people who use drugs and those around them, including their families, but the community as well. Yeah.
Thank you. Y fueron 24 países, ¿no? Que se compararon de cuál era su política y cuál era su uso de drogas. Y no hubo una relación entre si era más prohibicionista o más liberal con el número de personas que usaban drogas, ¿no? Que eso es lo que nos está diciendo, que siempre es muy interesante. I'm not too sure about this new question, but they are about treatment and what would be the difference between different types of treatments for opioid problems.
So, so in terms of, both methadone and buprenorphine are classified by the World Health Organization as essential medicines for the treatment of opioid dependence. And for the WHO to do that, it means there has to be a lot of evidence and you have to put forward a case, it gets reviewed, all that kind of thing. There's not that many essential medicines. So I think that really is a reflection of the very good evidence that both of those medications are very effective. They're effective in assisting people to reduce or stabilise their use, but both people who are in those forms of treatment also tend to improve in a wide range of other areas. So reducing drug use overall, reducing risk behaviour, and therefore reducing risk of contracting HIV and hepatitis C. But it also, they reduce the risk of overdose. So when people are receiving those medications, they're much less likely to have a non-fatal or fatal overdose. But also a range of other health outcomes, including reducing the risk of suicide. So they're two medications that, sometimes that can be difficult for people to grasp why you would want to give an opioid medication to someone who is opioid dependent. But it really allows people to, instead of having, a sort of what can often be a chaotic life in terms of getting money to buy drugs and sort of going up and down, sort of they're longer acting, and so they allow people to stabilise and not experience the really acute highs and then experience some withdrawal, but just to be stabilised. There are a lot of other interventions, so long-acting naltrexone is also available in the United States and some other places. That is an opioid antagonist, so it basically blocks opioids from your body. It is used, but it's not a particularly popular medication for people who are opioid dependent. But when people are on it, they're much less likely to use opioids because you won't get much of an effect, if anything. And then there's a range of other things, including counselling, inpatient therapy and all of those things. And while people are in inpatient treatment settings, often their drug use will reduce. But the issue becomes what happens when you leave that inpatient facility, and how do people maintain the kind of gains? And sometimes that is difficult for people to do. So.
Thank you. That's all the questions I have. ¿Tiene alguien más otra pregunta, comentario o algo que quisiera añadir? Ok, perfecto.
So I was thinking, like, is there a reason for governments to not get involved in these treatments? Like, is it very expensive? It's not important?
That's a great question.
Who's listening to this talk? So the first, methadone is an incredibly cheap medication. So it's very, very cheap to manufacture, and it doesn't cost a lot of money. Buprenorphine is more expensive, and that can be financially difficult for countries where there's not a lot of, the difficult decisions have to be made around what medications a country can afford. So in terms of countries with fewer resources, and fewer resources being able to be made for the treatment of people who are drug dependent, methadone is you can, but not every, there's a few hurdles that you've got to get over. But I think, as with drug policy, I think countries, governments and the community vary in their interest in making treatment available, which is, I think, why you see coverage being pretty low. Because I think, sometimes people don't have very positive attitudes towards people who use drugs. So I think that can turn into a lack of willingness politically and at the community level to implement these interventions, which is sad, because it's, these interventions are a way for people who use drugs to not be using drugs when they had caused them a problem. And the benefits aren't only to the person who's using drugs, it's also their family, children. There's really wide benefits for having someone being treated effectively for this problem. Yeah.
Thank you.
Thank you. I was wondering, since you know about the pharmacology of it, are you aware of the literature in ibogaine as a treatment? And if so, what are your thoughts about it?
I wouldn't say I was fluent in that literature. Also, I'm not really a pharmacology person. No, yes, I am aware of it, and it does get brought up repeatedly. I'm not sure how strong the evidence is. I don't know if someone else might be more of a... No, yeah, Matt, anything? No, yeah. It is something that people are interested in exploring, but it hasn't really been subjected to the same kinds of scientific study as I understand it. Yeah.
And as a budget treatment, is it cheaper than methadone? Might it be? Because it's a plant, simply it's a tree, so it's easy to get.
Yeah, but tobacco is also a plant, and it costs money to do that properly. And if you're talking about a medicine, you've got to get it from the plant, and if you're prescribing it as a medicine, it's got to be pharmaceutical drug grade, and that does carry costs. So it might not cost much to make it, but to make it into a medicine, it does. You can either synthesize it or you can extract it from the plant, but both of those things are a technical process that require money. So, yeah.
That's it. Thank you.
Tú tenías una pregunta, Claudia.
I have a question. I was wondering about the interpretation of the Latin American data, because you showed a significant decrease in the estimate of people who inject drugs, and also a decrease in the needles exchange programs and OAT. So what are your thoughts on that?
Yep. So the reason for the change in the prevalence estimate, so when I was talking in my talk, I was saying, Sometimes changes reflect new data, but it's using a different study methodology and might be a better estimate or whatever. The previous estimate was a published report and a study that had been done, but there had been, so we used it because that's what was available. There was concern that estimate, I think it was the Brazilian estimate, and there was concern that estimate was too high, didn't reflect the actual level of injecting occurring in that country. And a study between the two reviews that we did, a new study was undertaken and it came up with a much lower estimate. So I don't know if it really reflects a change in the actual number of people injecting, but probably an improvement in the method of estimation that came up with a more reliable estimate. In terms of the withdrawal of services, it's not related to a change in the number of people injecting. I suspect it's just a shift in the government's willingness to provide services. Yeah.
Mm-hmm. And a second question also related to that, do you think that it's also related to the funding that we get for studying both people who inject drugs and also to the provision of treatment? I'm thinking maybe we don't have any more estimates because there is no funding and that's decreasing the estimate.
Yep, so definitely sometimes, particularly when countries are providing services through funding from international agencies, if they stop providing that funding, that can really affect the viability of programs in the country, because the country may legitimately not be able to provide the funding without external funding, but sometimes it's also, they're also not interested in doing it, so it's, yeah.
Thank you. ¿Otras preguntas? I was wondering the relation between the availability for pain medication and the availability in the illegal market. How does it play when there's no availability for pain management?
Yeah, I think, I mean, as you will know very well, most countries sadly don't have sufficient availability of opioids for pain. Does that lead to an illicit market? I don't know that drug traffickers are thinking about supplying the pain population with pain management, but it is certainly the case that when you talk to people who have significant drug use problems, they often have pain problems. I don't know that drives people to supply the illicit market, but it often makes it very difficult once people have developed a problem with opioids, if they do have a chronic pain problem, how you manage that if they're choosing to not use opioids anymore. So, yeah. Yeah.
Okay. ¿Alguna otra pregunta? Okay.
First of all, congratulations. It's a very interesting conference, and you show us, I'm nervous. My English is not good at all, but
It's better than my Spanish.
maybe. But there's some percentages that you show us, and I think that is important to consider it, because regarding the HIV, the most of the risk and harm reductions strategies. Oh my God, I know. Yo puedo. Some of the strategies of risk and harm reductions in Mexico, and I think that all the countries are focused on HIV, but you show us that the hepatitis,
Yeah.
something like that. It's almost an important data. So I will like to I would like to know what kind of strategies do you think that we can implement to
Reduce.
Exactly. Thank you. To reduce this percentage, because my question is because the NGOs in Mexico are thinking something like that. No, we usually focus on HIV in people who inject drugs, but not. But generally, we don't know that is important this infection, such as the HIV. So I don't know if I explain my question.
So, as in, because, is your question around services not solely focusing on HIV because they're missing other, that means they're not thinking about other health risks, or?
No sé. Ajá, me refiero. Ajá, como que las estrategias están en VIH, pero no tanto en hepatitis B. No sé cómo preguntar eso.
Okay, he's interested in hepatitis C because I mean the rate of infection in hepatitis C among drug users is around 80% in Mexico.
Wow.
Yeah, well, the ones we have studied that are biased, as you know.
Yeah. Yeah, I mean, look, it's the same, well, it historically was the same in Australia. So we have virtually no HIV among people who inject drugs in Australia. We never have. But hepatitis C was very common. And I guess needle and syringe programs are also important for hepatitis C, but I guess the good news for hepatitis C is there are now really effective treatments that actually cure the disease. So the issue there becomes, how do you, like with drug treatment, how can you make that medication available, particularly for people who inject drugs, who are in many countries, not all, but in many countries that they form a substantial proportion of people who are living with hepatitis C. I don't know what the availability of hepatitis C medications is in Mexico.
Well, it's available, but it's very expensive yet.
Yeah, and do people need to pay for it themselves? Yeah.
Well, I don't know the new, I don't know, sí, but eso, sí, que en México o sea, la nueva política de dar medicamentos gratis incluye el medicamento para la hepatitis C. ¿Sí lo incluye?
Sí.
Yes, the new policy of making medications available for free for people who go to care includes hepatitis C, so that will...
Great, yeah. That will be really important. So I think, in terms of, implementation work, working out how to make accessing hepatitis C treatment relatively easy for people who inject drugs will be a really important thing to do. So,
Correct. Yeah. Clarita.
Yo solo agregar a tu pregunta, que es bien importante, sobre lo que están haciendo las organizaciones de la sociedad civil, particularmente en el norte de México, en la frontera donde digamos que el fentanilo ingresó, llegando a estas comunidades que están en alta vulnerabilidad. Algunas otras estrategias de reducción de daños que sí van focalizadas al tratamiento, a vincular o a navegar a las comunidades al tratamiento para VIH o hepatitis C, también incluyen con los riesgos del fentanilo, por ejemplo, el empleo de naloxona. Es muy importante, que es el antídoto que revierte una sobredosis. También lo que están haciendo es trabajar para que la comunidad, por ejemplo, no esté sola, si vas bajo el modelo de reducción de riesgos y daños, que no estés sola o solo si vas a consumir, por el riesgo eventual de una sobredosis. Es como otra de lo que se trabaja con las comunidades. Que no compartas tus jeringas, que hagas intercambios, otra medida principal, digamos que una de las principales de reducción de riesgos y daños. Y además de esto, por ejemplo, si ves que te sale un cuerazo, un absceso cutáneo, una lesión, que puedas asistir a alguna de las clínicas como es Preve en Casa, que es una ONG en Tijuana, para que puedan atenderte tu clínica. Que trates de no mezclar, porque hay mucho la mezcla de fentanilo con metanfetamina. Digamos que son como en general algunas de las condiciones, siempre tratando de vincular a la población también a tratamientos si así lo desean, pero va muy enfocado a tratar de que la población pues no caiga en sobredosis por el riesgo de la adulteración con fentanilo. Bueno, usted puede hacer un resumen doctoral. Por favor, ya lo voy a hacer. Thank you so much.
I'd like to make a comment and also to make a question. My comment is that, about your question, why, if we know that methadone and buprenorphine are working well, why we're not using it? You want to know that? Because people do not think that it is a health problem. People think that it's a moral problem. So if it's something that has to do with your will, is your problem. It's not ours. So I think that that's very important. We have evidence that medication-assisted program with methadone mainly and buprenorphine works well, extremely well. And we only have 2 public clinics in the country. So that's a comment that I think is very important to make, because it's not because the evidence is not good. It's very, very sound. And my question is about the same thing regarding Russia, because they don't use methadone and buprenorphine. They only use antagonists. What do you think about it? And does it work well? What happens with people? I mean, they are not allowed to ask for a specific treatment. They have to receive something that is an antagonist because of the ideology of the country. They think that any agonist, any drug that is similar to heroin or to whatever, it's awful. And because of that, they do not use methadone or buprenorphine. They only use antagonists. Can you tell us something about it?
Yeah, I mean, I think the Russian Federation is a really good example of what you mentioned around, you know, people thinking that this is a moral thing, not a health or a social issue. My understanding, I haven't been there, so but just from colleagues who have, and particularly colleagues in the UN, is there is a very strong culture within the specialists who provide drug treatment in Russia, which will not, at least with the current cohort of doctors, that will not change. They will not change that view. Doesn't matter what the evidence says. That it's a view not around what the benefits are. It's a view that this is the wrong thing to do. So yes, so they have naltrexone available. There's oral naltrexone and also a long-acting formulation that gets injected. As I sort of mentioned before, oral naltrexone is rarely used because basically all you need to do is not take it one day because you want to take drugs and it ceases to work. And that's often what happens when people don't stay in treatment. The other issue with that is once you've been on naltrexone, you lose your tolerance to opioids. And this is one of the really big things also about when people leave inpatient treatment. Once you haven't been using for a while, your tolerance to opioids goes down a lot, and particularly when you've had naltrexone, which sort of bumps everything off, and your tolerance goes back to not necessarily zero. I'm not a pharmacologist, so I will call it zero. But what happens is when people return to use, they return to using the way that they were before when they did have tolerance. And so it's incredibly risky in terms of a risk of overdose. So oral naltrexone is not really used. The long-acting one is used more, and particularly in Russia. And it can provide, I mean, there's varying formulations from 1 month to up to 6 months. It's the only thing people can get if they want treatment. The evidence is not as strong around, like it just hasn't been subjected to as much, standard randomized control trial study as methadone and buprenorphine have been. But the risk you have with the long-acting formulation is it will wear off over time. and you'll have the same issue as you have when you've been abstinent from opioids in other ways, and that if you return to use because you don't want to use it anymore, your risk of overdose will be very high. And particularly in some countries where there's not a huge amount of sort of casework follow-up with people, if you're not providing other kinds of support to people and making sure that they understand the risks if they return to use, you really it's placing their lives at risk. So that is one of the concerns.
Okay. Sorry. I have another question. We're talking about stigma and how it affects harm reduction services in other countries, but I couldn't help to notice that in Australasia, the rate of harm reduction services is higher. What do you think Australia did right to increase this rate? Do you think there's less stigma in Australia, and what can we do in this setting?
Well, it's a very kind observation about Australia. I won't boast. I have nothing to do with it either, so I really can't. So the thing about Australia is right from the beginning. So we've had both needle and syringe programs and OAT for decades. So they're very long-standing programs. NSPs were originally introduced in the 1980s, and that was when there was real concern that HIV, when HIV was, people were becoming aware of it, and people have attributed the low rate of HIV, which we've always had, to the fact that it never came into the population because we had those interventions. When they started off, they were, people, by people I mean the clinicians and other staff were very brave in starting off these services because they did it at considerable risk to themselves, not from the community and perception. But I think what we've had in Australia is government willingness to actually provide these things in a programmatic way, not in an ad hoc way. And I guess we're fortunate that, it varies, but at least where I live in New South Wales, the government, because most of the drug treatment and harm reduction is delivered through the states, not through a nationally. And our state government is pretty receptive to evidence around for these interventions. So I think we're lucky that we've got those kinds of policymakers and people in power and people willing to listen to evidence. But it doesn't mean there's no stigma. There is certainly stigma in Australia, and it's not just in the community. It's also in people who are providing the services themselves. And I think it's unfortunately lots of doctors don't have very good attitudes towards people who inject drugs or people who use drugs. That they can have pretty negative attitudes, and I think it's something that we have to continually be working on. So you're all doing psychology, I think. Yes. So it's something really to be mindful of. I did psychology too. It can be easy to slip into it's them versus us, and that's as clinicians as well. And I think people are just people, and I think it's a really something to always try and be mindful of around, that kind of, they call it othering, that they're not, they are not yourselves, but they're not others, they're just people. And even in the really good hospitals in Sydney where I live, I've seen pretty poor attitudes from medical staff, and I think it's something that we have to keep working at all the time, all of us. Yeah.
Muchas gracias por tu pregunta. Creo que también tiene que ver con el hecho de que en México la salud mental y las adicciones en realidad no estuvieron incorporados al sistema de salud, que es donde se van a curar. Y hemos visto muchas estrategias en los estados donde tienen problemas de este tipo, de drogas duras y gente que realmente necesita la intervención para no morir y demás, donde las personas que han estado en tratamiento en las ONGs, si son por ejemplo enfermeras, trabajan en los hospitales y cuando llega un enfermo les hablan para que vayan a rescatarlo y realmente le den atención, ¿no? Porque es una situación bastante dolorosa. y porque hay una percepción muy equivocada de que las personas, por ejemplo, que se inyectan heroína, se van a morir muy rápido. Y eso sabemos que no es cierto, ¿no? Entonces, un poco las preguntas eran, ¿y por qué te interesa eso si se van a morir rápido, ¿no? Y entonces, creo que antes del VIH había esa percepción, ¿no? De que se morían muy rápido, cuando para identificar a las personas que eran positivas y no lo sabían, la única manera era salir a la comunidad, no estar esperando en las instituciones, ¿no? Y ahí se pudo ver claramente que estas personas tenían una vida terrible y sufrían muchísimo, pero vivían muchos años, y que la pérdida no era nada más para la persona, como se ha dicho, sino para todo el mundo, y empezó a haber un cambio, pero aquí todavía estamos lejos de lograrlo, ¿no? Entonces, y tenemos muchas pruebas actuales de que eso sigue siendo desafortunadamente cierto. Gracias por tu pregunta. I was telling them that people in Mexico think, what authorities, doctors don't like them either, but doctors think that they're going to die very quickly. And it's like why outreach programs for HIV that we could really had information that people that inject drugs can live many years. Okay, ¿una nueva pregunta? Bueno. Muy bien. Y con eso terminamos.
I love questions, sorry. Given that you mentioned that a substantial amount of people who inject drugs are suffering from pain problems, do you think cannabis legalization could be a useful way to reduce the need for opioids as painkillers and replace it with a marginally less harmful compound, given that THC also has profound like pain-reducing effects?
The short answer is no, and then I'll give you the longer answer. So we reviewed all of the evidence for cannabis and cannabinoids for a range of health issues, including chronic pain, and the evidence is actually not very strong at all. Yeah, it's not. But having said that, the use of opioids for chronic pain the evidence around that is also not very strong. So, yeah, I don't think that making cannabis legal would mean that people who inject drugs stop injecting opioids. Would be my.
Y pues aquí está con nosotros la especialista, la doctora Nayeli. Quizá luego te puedas acercar a ella para hacerle esta pregunta sobre los parches de marihuana. O sea, cuando no tienes acceso a muchas otras medicinas es una opción, pero ella te puede explicar. O sea, no va nunca a ser mejores o más efectivas para manejo del dolor que los opiáceos, ¿no? Pero si no tienes, puedes hacer un buen uso de ellos, ¿no? Pero si quieres luego puedes hablar con ella, que es la que sabe del tema. Ok, muchísimas gracias.